This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
From an investment rationale, there's a reflection of what is the best business model to deploy this transformation. Today's business model for most health systems hasn't changed in decades. They're fee-for-service. Their biggest cost structure is people, and it's a capital-intensive business. And all of this needs to be calibrated in a very traditional way, and that hasn't changed for a long time. As we start to move a business model that becomes maybe more tech-enabled or more consumer-centric, the way in which they actually capture revenue could change very differently from the fee-for-service episodic model to something that looks more like concierge medicine today, looks more like subscription, looks more like recurring revenue.
Hello and welcome to Sg2 Perspectives. I'm your host, Tori Richie. Today we have two experts from the Vizient Sg2 strategy consulting team, Heidi Pandya and Mike Strilesky. And we're going to talk all about care delivery transformation. Heidi, Mike, thank you for joining.
Thanks for the opportunity.
Thanks for being here.
Mike, I'm going to kick the first question to you. In terms of broad strokes, what are consulting clients thinking about right now as it relates to care delivery transformation?
The two main drivers of care delivery transformation right now have to do with capacity and workforce. For the purpose of this discussion, let's just kind of focus on capacity because that's going to be the dominant theme that's going to drive some innovation, use of technology, and some of the strategies going forward. Workforce is going to be a market-dependent issue and is a bit of a governor on how change can be implemented over time.
As it relates to capacity challenges, certainly if we look at some of the recent historical utilization trends, we see the inpatient discharges, ED admits, those are up year over year. Does it seem to be an instance of folks aren't leveraging the right sites of care or the right level of acuity within the sites of care they go to? Is it starting even before that in terms of just ability to access those ambulatory care sites? What do you get the sense is going on here?
Tori, it's so multifaceted. It's everything that you said and then some. Taking the step back, thinking about the system of care. Do we have the right access points for patients to get upstream and really see them out in the communities, meet them where they are? But then as we start to bring in those challenges organizations are facing to the ability to recruit physicians, as we think about some of those rural hospitals out there, then as we think about the ability to bring in the workforce to care for patients across those variable communities you talked about, we're really seeing all of these different dynamics play in, and it's impacting different organizations in different communities across the spectrum in multifaceted ways.
All of those things are what our clients are asking us to try to solve for and address. Sg2 has been forecasting the rise in patient acuity. That's probably the biggest sub-theme to all of this. The needs of patients, the prevalence of multiple chronic disease, so therefore the demands on the care team, the number of different specialists that might need to be available to interact with that patient when they're in the hospital. All of that is driving patients to higher acuity sites like academic medical centers, major referral centers. And because of those complexities, the ability to keep patients in communities on a consistent basis is compromised.
To that end, some of the latest data that's come out of Vizient's clinical database. If you look at utilization trends over the last year, there's been growth across every service line for the most part. And so that says to me that this is something beyond just simply acuity, because if it was just acuity, it would be consolidated. The growth would be to very specific clinical areas. Yes, acuity is rising. That's pushing people to the tertiary and quaternary facilities. But I'm wondering if those tertiary and quaternary facilities really need to wrap their arms around how do they improve network and alignment to decant some of those lower acuity patients that are also growing right now, that are also showing up into those care sites.
This is honestly where you get into the workforce discussion. In an integrated delivery system, what they're finding is they have to staff the referral center 24/7, 365. There's no ability to change that model. And where they tend to sacrifice coverage and or staffing levels is the further you get away from that facility. Yes, the acuity could be provided somewhere else, but they don't often have the resources to provide that care somewhere else. This is the inherent conflict that they're in from a workforce standpoint. Now, from a reimbursement standpoint, we can kind of layer that on top. The reimbursement that they get in those community sites doesn't allow them to pay the premium for the workforce to staff those locations, while it does typically, or at least more easily, is justified at the academic medical center or the referral center where they have higher rates. So there's absolutely a financial component to this that's both top line as well as workforce related.
So how do people go about starting to solve this issue? Because the reality is you can't always build your way out from a physical infrastructure perspective. How do we start to then transform the way it is that we're going to market to help then reduce some of the capacity burdens that organizations are feeling today?
I want to underscore something you said about building, nor would we recommend you build your way out. I think we keep coming back to workforce. Even if you could build it, you can't necessarily staff it. It's really driving the way we're thinking about solutions differently. And then what are those innovative solutions? So we see organizations, and I'm seeing more and more of this across strategies we're building, things like virtual nursing coming into play and having great success in virtual nursing. We're seeing the continued adoption of care at home strategy that is helping organizations deliver differently and in innovative ways, and through innovative partnerships as well to really expand upon the care delivery. Those are just three of the things that I'm really seeing across organizations right now.
That's so exciting. Do you have any examples of some innovative partnerships that you've seen play out across customers or markets?
It's all about elevating the level of care that you can provide in a market so that those patients can stay local. The way in which you get there, there's obviously a technology component that could be leveraged. There's clearly a workforce dependency issue. There is a legitimate investment in this. So depending on how the partnership is structured, the immediate financials of that activity may benefit one and may be more of an investment for the other. If you're on the investment side of supporting that program, you have to create your financial rationale around the downstream activity that you're going to get from that market and accrue someplace else. So it becomes complicated in how you structure the partnership and how it's communicated and financially justified.
And Tori, some of the fun, for lack of better words, organizations that we're seeing, really come into healthcare and start to see partnerships. We all know Best Buy made its way into the healthcare industry. They're really spreading their footprint across organizations. We're seeing on the West Coast, some of the academics that are partnering with them in different care delivery, whether it's urgent care at home, emergency department at home, taking that concierge care back. Ultimately, as we think about different ways that we're even managing that patient experience and the delivery. In my past life, in one of our organizations, we brought virtual reality into the children's hospital and really helped calm the pediatric patients down through the use of VR and images that they were watching and such. So it's been exciting to see us try to make those efforts in healthcare where at times we've felt like a stagnant industry.
I guess to just push that conversation a bit further, my follow-up question to what is pretty robust investment that's required on the health system side, given the financial picture right now, is there appetite across most organizations to make some of these more proactive investments because they understand perhaps what the ROI is if they're able to de-escalate the patient population? I feel like sometimes we've been pretty slow to make those investments in the past, and I'm curious if that trend is starting to turn at all.
My experience and what I've witnessed working with organizations truly varies on the organization. That's like the most consultant answer I can provide to you. But, as I think about the stages where organizations are and even deploying their strategy, it's making sure we're doing the blocking and tackling. Let's get operations under control. Let's get back to that. We're past the pandemic phases. We're in our new normal. Let's make sure we're blocking and tackling. And some organizations are further along in their journey and their ability to really focus in that innovative and that investment. Some of that comes down to the individuals within the organization that are pushing for these types of technologies and making the case. In some instances, the research is still early in showing the proof of concept. So some of our early adopters and early adopter organizations, though, are the ones that are pulling that research together. I still see a wide journey and people across that continuum in different places. But what I am starting to see more of, and I know advocates really pushed for this, is the innovation centers. Those organizations that are making the investment in some of those innovation centers that are focused on changes in care delivery, the technologies, and making sure there's some FTEs or some resources truly dedicated to thinking that way. They're the ones that are pushing this forward.
From an investment rationale, there's a reflection of what is the best business model to deploy this transformation. And today's business model for most health systems hasn't changed in decades. They're fee for service. Their biggest cost structure is people, and it's a capital intensive business. All of this needs to be calibrated in a very traditional way, and that hasn't changed for a long time. As we start to move a business model that becomes more tech-enabled or more consumer-centric, the way in which they actually capture revenue could change very differently from the fee-for-service episodic model to something that looks more like concierge medicine today, looks more like subscription, looks more like recurring revenue, and that will disrupt the business model of the payers. This is going to be interesting to see if healthcare can actually make that transition, like a lot of other industries have made this transition. That's really been the story for anything that's retail consumer focused today. Is there's an interest, there's a need on the part of patients and consumers to experience care and seek care differently, but the payment mechanisms haven't really provided the right model to make it profitable and make it worthwhile for investment. And that's why we're starting to see some of these failures in the last year. The underlying business model wasn't supported with the right revenue model. One of the innovations that's happened in the last handful of years is the investment in transfer centers and really a technology-enabled platform with some predictive modeling that brings forward patient information in a more real-time manner to clinical experts to make the right determination as to where that patient should go. And rather than this being a decision that's just a default, we're going to go from point A to point B, somebody intervenes with better information and can redirect that patient elsewhere. And oftentimes that is not the location that the transfer center will determine is not going to be that academic medical center or the referral center. There's going to be a more appropriate and suitable alternative within an integrated delivery system where that patient can be moved to. And I think that helps everybody. Usually that's going to be a closer location to home. There's going to be capacity there, which allows the system to more effectively manage their resources, and they've freed up capacity for higher acuity patients at the main campus. Transfer centers have shown to improve quality in that way, lower length of stay. It does bring up some challenges around upfront investment, and it does change your staffing model around how you manage this.
It's an excellent point because as I work with organizations that are still thinking about virtual care and delivering in a virtual, which is starting place for many, the question becomes, what is the reimbursement and does this financially make sense for me? It's our reimbursement model that's actually holding back some of that innovation and the ability to deliver to consumers and the way they want to receive their care, the way they're seeking their care, and what they've learned to expect. As we've gone through changes and where the pandemic really did push us forward, we're pulling back a little bit. As an industry, we need to think through what that means. And we're seeing, I know legislatively, some further support around virtual care. We're hoping that will continue to push forward, but that really can be a telling of how quickly will we continue to adopt, especially from a care delivery perspective, which is where I see some organizations on the AI front, as we think about starting to implement technology. They're starting in places like revenue cycle. Where we expect that to go to, though, is AI-enabled care delivery, surgical care, et cetera.
It's an interesting line of discussion because in my mind, it's a vicious cycle. We are currently dealing with an incredibly resource-constrained environment in which patient acuity is continuing to increase. Access is continuing to diminish, and patients are asking for new ways in which they can receive care upstream. And it gets back to, if we perhaps make some of these investments, if we perhaps reimagine how it is that we are incentivizing not only our workforce, but also payers, can we start to really move the tide then on de-escalating some of those comorbidities that patients are having, shift away from this very episodic mindset mindset of patient A comes through the front door with this healthcare concern today. So that's all that we're going to focus on. We're not going to think about perhaps any of the downstream needs that they might require. And if we start to change that approach to care, how then can we improve not only population health, but also some of the efficiencies that occur within the system?
Tori, I think you are focused on something so important that gets sometimes lost in the conversation, which is going upstream of the care and to the population health, but the prevention. And so how do we get ahead of patients even needing access? They have the access when they need it, but how do we go back to the population and focus on healthcare and healthcare delivery and wellness of communities? And then how do we avoid the admission? And then their readmission altogether. That's very often a miss. We're focused as an industry so much on the episodic and the symptoms that come in versus getting upstream. And I think that's part of this dialogue absolutely as well. And changing the way that we're thinking about health and focused on treating sick patients to how do we keep the population from getting sick.
How do you keep especially the complex medical patients out of your acute sites of care so that you have the capacity for the incredibly complex surgical patients, which we know drive higher levels of reimbursement? It's how do you not only meet patient need and think proactively about the care you should provide to them, but then how do you also remain resilient from a financial perspective? If we were to get a little bit creative here, and if you were to start fresh and build a new delivery system without staying beholden to the infrastructure of today, we could probably achieve both goals.
I think that's right. When we think of your ambulatory strategy and how that supports your acute care strategy, there's a component of the ambulatory space that needs to still be focused on that higher acuity patient. Those exact issues around how are we creating access for the most at risk or most in need patients that likely are being readmitted or that are frequent flyers. And we've got to create a different access model to address the needs of those patients. And then we've got more of a transactional patient and or a preventative care patient that needs a different access strategy and might need a different business model to make that work. Today, most everybody's applying the same approach to all three segments, and they're reinforcing the providers and the operators who run those ambulatory sites to focus on access metrics that apply to everybody. They're focusing on productivity, and they're focusing on attributed lives and new patient visits. And they're assuming, and we all can fall into this trap, we're assuming that elevating levels of all of those metrics improves the situation, when in fact it may not. It really requires, in a market, you to challenge yourself. If you've only got a handful of primary care physicians that you employ in your health system, what kinds of patients do you want those primary care physicians to see? And is their business model set up to actually manage those kinds of patients, or are they trying to see everybody equally?
Have you all had productive conversations with health systems along this line? Because a concept that we've been talking about for a couple of years now is this idea that you can't be all things to all people, and you need to get very specific with the consumer segments that you want to invest in and really grow loyalty. In conversations I've had with folks, there's this recognition that perhaps that needs to happen, but I haven't really seen much action in terms of strategically deprioritizing select patient cohorts in favor of others. Have you started to have those conversations? Have you started to see the tide turn at all?
It's probably anti to the mission. We have seen it for years in terms of patient segmentation and prioritization work is around anything that's value-based care attributed. So where they've had ACOs, where they've had Medicare Advantage at-risk contracts, where they've been at risk for certain patient populations, they've adjusted their approaches to cater to those and they've accommodated it. So it's always been in that direction. I don't think they've reached that point yet where most systems are willing to say for these lower acuity patients or these transactional types of patients in our market, we just want to have a different business model to serve those needs, with the exception of some of the urgent care partnerships that we've seen in markets where they've brought in that partner. But I don't think they're connecting it to, they just view it as incremental, not necessarily as being an alternative to their primary care strategy.
Mike, you bring up such an excellent point because the deselection can be hard. And ultimately, especially once we've gotten started, no one wants to let something go because we want to try to see it through. So your point, and maybe changing the way we're phrasing it from deselection to your point to what's the different business model? Because until we reach a point that health systems across a community could actually come together and say, here's how we're going to work collectively to care for the community, we can't deselect because there will be a whole set of patients that will not have access elsewhere. Ultimately, thinking about tying together the mission to your point, but also we can't prioritize everything, but we can offer what we need to be the community hospital, for example, but we don't have to deliver to everyone in the same way. And Mike, I think that's a very well taken point that we need to change the framework or our thinking in that way to how do we change our care delivery based upon patient segmentation, based upon the acuity and the needs of different service lines and different patients across those service lines.
Mike, Heidi, thank you for joining this discussion. I think this is such a complex but timely topic that organizations are really trying to wrap their arms around. To close us out, I'm curious if each of you had to pick a place for organizations to start this work. What is that first step? What do you recommend? Heidi, I'll start with you.
I'm going to go back to basics about going back to your strategic plan and understanding where your long-term journey is. Right now, mostly we're focused on 3 to 5 year plan, but really being strategic and thoughtful and where those investments as we think about care delivery can truly help an organization to achieve their vision. And really focus on, and when I say that, it's not just all about growth, it's about that broader enterprise plan and really thinking about the quality journey, the patient experience journey, bringing that together with the strategic growth journey and where can that change and that innovation in care delivery accelerate and support across that horizontal story. And so take that step back, as Mike said, you don't have to be all things to all people and be very thoughtful and where those investments are. If you're going down that journey and it's not working, it's why you have your key performance metrics. Don't be afraid to stop and pivot and try something different. Fast failure and pivot.
Where I would start, the care delivery transformation work that I think is most impactful today are things that our operators can recognize we can implement soon. There isn't a inherent capital investment or technology integration that's dependent on us being able to do something. When we look at the surgical sites and how do we optimize where surgeries are done, that's probably the most impactful place to begin with care delivery transformation. There's, in many cases, underutilized OR capacity in some locations and a challenge in others. How you distribute that surgical activity is both financially beneficial, but also operationally beneficial. And you can actually process through the backlog and or achieve some of your growth goals with that appropriate distribution. That's not necessarily innovative in many ways. It's very operational, but it's the front end win that's necessary to say we have to do things differently. So if we're on a care delivery transformation journey, we have to start with doing something different. And that's a great place to start because most health systems have the ability to focus on that.
So optimize site of care operations, fail fast, and connect to your strategic plan. Great insights. Thank you so much for joining today.
Thanks, Tori.
Thank you.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.